Welcome everybody. It's nice to see a full house here on our first Scholarship Across the Discipline panel this semester. This is an event that we've been holding for this is our third year actually doing this. The idea is to bring together faculty scholars to present on their research from different disciplinary perspectives on a related topic. So we're excited this year to expand and include faculty from the School of Medicine and from the School of Health Sciences for a panel on an interesting topic, I think, on bacteria, viruses, and vaccines. We have two other panels scheduled for this semester that I wanted to let you know about. Coming up on October 9th at 3 o'clock, right here, we have a panel on bioethics focusing on end-of-life care. And that fits within the theme for the campus this semester. It's the week before the Henrietta Lacks talk, so it would be interesting, I think, for people to come and hear this conversation as well as the Henrietta Lacks conversation. On November 13th, our panel will focus on living on the margins. So we'll be looking at people who are marginalized within our culture, such as people with disabilities and homosexuality. Today, as I said, we have an exciting panel. Our first speaker will be Thomas Murray, who's an assistant professor of medical sciences in the School of Medicine. He's a pediatrician and researcher who specializes in childhood infectious disease. Our second speaker will be Lisa Cuchara, who's professor of biomedical sciences in the School of Health Sciences. She teaches courses in immunology to both undergraduates and graduate students. And you may not know, she's an accomplished photographer as well. And our third speaker will be David Hill, who's professor of medical sciences in the School of Medicine. And his work focuses on infectious diseases and global health. Each speaker will have about 15 to 20 minutes to present their research. And then we'll open it up for questions and discussion. So we'll hold the questions until the end. And encourage everybody to jot down your ideas and engage us at the end. So without further ado, I'll introduce Dr. Murray.
Great. Thank you all for coming on this beautiful Tuesday afternoon. My training is in pediatric infectious disease. So the research project I'm going to tell you about today is one example of the kinds of things we're trying to do to prevent infections in a group of children that are at risk for significant chronic and life-threatening disease. All research talks should start with a conflict of interest. This study was supported by a contract from the Yale New Haven Microbiology Laboratory from the Cystic Fibrosis Foundation. However, I didn't get any money and I have no vested interest in any of the commercial things that I'm going to tell you about today. I didn't get a penny, unfortunately. So our story will start with a group of children whose care I've been very involved in the past 5 to 10 years, and those are children with cystic fibrosis. This is a genetic disease that affects about 1 in 2,500 births, and the genetic defect leads to a problem in salt and water transport in the cells. So essentially, this is a multisystemic disease, which means it affects many parts of the body, but for the sake of this talk, we're really going to focus on the lungs and what happens in the lungs of these children and later on adults. And because of the problem with water transport, essentially what happens is the mucus that we all get is much thicker in these children. So it's really, really thick mucus, which means they can't cough it up. Like we get a cold, we cough, 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 up comes the nasty stuff. They have a really hard time coughing that stuff up. So when that mucus stays in the lungs, the next problem then is bacteria love that. This is a place where bacteria and other infectious agents can grow and thrive and cause problems for these children. And one of the hallmarks of this disease is frequent hospitalizations with essentially a chronic pneumonia and what are called exacerbations of their illness. So this is a complex world in terms of taking care of children who have these lung infections. And when I started, it was all about this gram-negative organism called Pseudomonas aeruginosa, which is a bacteria that's in water. It's everywhere. We all drink it every day. And if we're healthy, it doesn't bother us. Our immune system is able to clear it, no problem. However, in these children, when they breathe it into their lungs, it can cause significant infection. In the past 5 to 10 years, methicillin-resistant Staph aureus, or MRSA, which I'm sure many of you have heard about, has become increasingly recognized as a problem for these children. And then more recently, viruses, such as the respiratory viruses that many of us have experienced in the last couple of weeks, have been found as the diagnostics have improved, and co-infection between the bacteria and the virus seems to be a really important cause of causing these children to have difficulty breathing and bringing them into the hospital. And finally, in microbiology, which is the other world that I like to live in, they've gotten very fancy with the diagnostic technology. So it used to be that we would just grow things, right? The microbiology lab was a farm. If you could grow something, you'd see what you grew, and it was a farm to grow things. But now, we have these molecular techniques where we look for the DNA and the RNA of the infectious agents without growing them. And when you do this, what we find in the lungs of children and adults with cystic fibrosis is there's all kinds of interesting and new bacteria, viruses, fungi, atypical bacteria. And what that means in terms of illness is an extremely active area of study. Nobody is really sure what these new organisms mean in terms of making the children sick. It's very clear that for Pseudomonas aeruginosa, this is a marker of morbidity and hospitalization for these children, and ultimately, unfortunately, death for these patients in adulthood. So with that in mind, what do you do about it, right? It's a big problem. How do you keep the lung as healthy as you can for as long as you can? And it really starts up here with prevention and prophylaxis, which is where I'm going to spend most of this talk today. It starts with prevention in that they now have newborn screening in the state of Connecticut. So every child in the state who's born with cystic fibrosis is identified within the first month of life. So you can immediately begin to act to try to preserve that lung and keep it healthy as long as possible. So how do we do that? Well, one of the ways we do it is with prophylactic antibiotics. You give them antibiotics to try to prevent infection. However, that will not work for all of the different organisms out there, and eventually these kids will get infection. And the next step then is diagnostics. We need to be able to rapidly identify what is the reason for their illness and then come up with the appropriate medicines to deal with it. And that gets to therapeutics. And in general, in the antibiotic world, so antibiotics are what we all take when we have bacterial infections. They don't work for viruses. That's an important point. There has not been a lot of movement with lots of new drugs. But in the CF world and in all patients with chronic lung infections, there's been a number of new drugs that are given through inhalation. So you breathe them in. And if you think about it, that can be very advantageous for a couple reasons. One, the side effects. So anybody here who's taken erythromycin has felt the GI side effects of taking erythromycin, right? It's not fun. There are lots of IV medications that are antibiotics that can also be problematic in terms of the effects on the kidney or the liver. If you breathe it in, a lot of those side effects go away, and it's much easier to take, and it gets directly to where the infection is, right? That's what you want for a drug. You want it to get where the bugs are. However, there's some problems with that as well. But it really all starts with infection control. And this is no longer a CF talk, this is an everybody talk. Infection control and hand washing is by far the most important thing you can do to prevent the spread of infectious disease. It's so important that I actually managed to give an hour talk on hand washing to the School of Nursing at Yale. And I thought it was surprising for two reasons. One, you could actually fill an hour talking about hand washing. And two, they invited me back the next year. Because I was like, would they really want to hear that again? But they did, and it's that important. It's important if you're a healthcare professional, but it's also important as you're out in a college campus, because this is the most common way that organisms are spread. We all like to touch our nose and eyes, whether we think we do or not, and then we like to touch people, and that's how we spread infection. The CDC has this thing called respiratory etiquette. I don't consider myself an expert on much etiquette, but in this I'll make an exception. And basically what this means is you were used to be taught to cough into your hand. You're not supposed to do that anymore unless you have a tissue. You cough into your sleeve. They don't want you coughing into your hand and then going to shake a bunch of people's hands. That's a bad idea. And then it all comes back to hand washing. So if you take away nothing else from anything I've told you, washing your hands is a good idea. And the alcohol stuff is fine too. So, however, that will not prevent a lot of lung infection in these children, because these inhalers, which are so important to delivering the antibiotics into the lung, are also a source of infection. So the idea is that if you have infection in your lungs and then you go to take the medicine, when you cough, or the secretions from your own respiratory area will get onto this machine, and then the bugs will survive on the plastic here. And they can survive in a number of different places: inside the mouthpiece, inside the nebulizer chamber, and inside the medication reservoir. So as more and more of the drugs are being delivered by this method, there's a number of studies that have shown that these are a potential source for lung infection. So the treatment can actually contribute to the disease. So this has been recognized, and what have people done about it? Well, there's absolutely no consensus on the best way to clean these. Everybody agrees they need to be cleaned, makes sense. But there's a number of different recommendations by a number of different national organizations like the Cystic Fibrosis Foundation. So you can put them in your dishwasher and put it on the sterilized cycle. That's one way you can do it. You can use just plain soap and water. It's another way you can try to clean these. Or you can actually boil some water on your stove and drop them in and try to decontaminate them that way. So each of these has advantages and disadvantages. The dishwasher is pretty easy, but it takes about 2 hours on a normal sterile cycle, plus or minus. This one, you really got to scrub all the nooks and crannies, and will you really get it out? And I don't think a lot of people want to boil water and drop their nebulizers in next to the spaghetti. So none of these have been ideal. However, there are these other machines out there for a totally different purpose, these baby bottle sterilizers. A lot of you look like you're too young to have children, but for those of us who do, I did use one of these once, and the bottles are really hot, so I never used it again, because I'm like, you're going to burn your kid's tongue, and he's like a month old, so that's not useful. But for this purpose, this has been proposed as an alternative method. So the idea is that it would be fast and easy, and these are the 3 different models that we studied. So we looked at each of these, and the idea is you put the nebulizer in there after it's been used, you put some tap water in, you hit the button, the cycle is generally about 10 minutes, and you're done. So if this works, it would be a great way for disinfection in the home for these children and their families. The other thing is you want something that's not going to disrupt their life. When people have chronic illness, you want to come up with ways for them to deal with their illness that do as little as possible to interrupt the things that they like to do. So our study was pretty simple. Our hypothesis was that these baby bottle steam sterilizers would be an effective and user-friendly method to disinfect home nebulizers. So we're just asking a simple question: does this work or not? We used 3 different inhalers that are shown here, and we placed the bacteria in 3 different spots in each inhaler. So for each of these inhalers, we would have 3 data points that we would look at. And the experimental design is very simple. You put it in the baby bottle sterilizer, it's no longer a baby bottle sterilizer. You put it in the inhaler sterilizer, you hit the button, you let it go, and then you culture it before and you culture it after, and you see what you recover. Does that make sense, everybody? No, I'm supposed to. So we did this on 6 different bacteria. All of these are known pathogens in patients with cystic fibrosis, but frankly also in many patients and adults with chronic lung disease, such as chronic obstructive pulmonary disease or bronchiectasis. So we did Pseudomonas aeruginosa, we did a mucoid Pseudomonas aeruginosa, which is exactly like it sounds. It's a version of Pseudomonas that makes a bunch of snot around it to protect it. We looked at MRSA, Haemophilus influenza, Burkholderia cepacia, and Stenotrophomonas multifida. There will be a quiz on this as you leave. And essentially the take-home message from this slide is we tried a bunch of different organisms, and the amounts that we used were about 500,000 to 1 million organisms on each spot. So it wasn't a little bit. It was quite a bit of bugs to see if this was going to work. And we tried 3 different conditions. The first was a dry sample, where after we put the bacteria on, we let it dry for a half an hour. So what this was meant to mimic is the person who uses the inhaler, throws it in their backpack and goes to school and leaves it there for a week and then goes to use it again. So it dries out. This you would presume would be bad for bacteria. Bacteria don't like to be dry. They prefer to be wet. So the second was the wet sample, where we put the bacteria on and we immediately put it in the machine and let it do its work. And then the third was one we were very interested in, and that is this thick sputum that I told you about earlier. Does it protect the bacteria from this disinfection? Can the bacteria encase themselves in this sputum so that even if it works, it may not work on bacteria that are coming from the lungs of a patient with really nasty sputum. So the way we did this was we took de-identified patients and sputum that was discarded in the lab that we were about to throw out, and we added our bacteria to this CF sputum and then added it to the inhaler and performed the experiments. Before I get to all those results, the first thing we wanted to do, getting back to ease of use, so one of the huge issues is everybody here could say, oh, well, of course you have to clean your inhalers. People don't do it. The studies show that about 60% of patients actually take the time to clean their inhalers, and some of this is because it's just hard to do. It takes time. They're busy kids. They're doing lots of other things. So we really wanted to look at whether or not you had to take the inhaler apart. Because if you can do it without taking it apart, it's a lot easier to take an inhaler that's assembled and drop it in than having to take all the pieces, put it in, take it out, put all the pieces back together again. And what we were able to find, just looking at Pseudomonas, the mock treatment, so for the mock treatment, which I thought was actually kind of funny, they inoculated it and put it in the machine and left it in the machine for 10 minutes without turning it on, and then took it out of the machine and recultured it. I thought that was a bit extreme. I thought you could have just waited 10 minutes, but I was overruled. And then the steam, this is after treatment. Basically, CFU is a colony-forming unit, which means it represents one bacteria. So in the mock, for all the sites, there was greater than 100,000 bacteria that we were able to recover, or essentially too many to count, and NG is no growth. So even in an assembled nebulizer, for all of the different inhalers and all of the different sterilizers we looked at, it worked. So for all of the remainder of our experiments, we just used assembled inhalers. And essentially, the take-home message is that it worked beautifully for the wet and the dry. So 4+ just means a lot of bacteria. For any organism, this is hundreds of data points summarized in this graph, and NG is no growth. So the take-home message is very clear, that this is a very effective way to disinfect these inhalers at home. However, we can't say for sure that it's sterile, although this would suggest it's sterile, because it's always possible that our technique was below the limit of detection. There could be a couple of bacteria that we didn't pick up on the swab that we missed, but clearly it was very effective. So I just wanted to give you a sense. I don't know if you guys can see this. These are bacterial plates, and these are from the sputum that we looked at. So what I hope you can see here are these white dots, which represents normal flora. So all of us, no matter how much we brush our teeth and no matter how much we scope or use Listerine, will have bacteria in our mouths, and that's okay. It's normal bacteria and it's healthy. And that will look like this. So the sputum that we used had bacteria in it to begin with, and then we added Pseudomonas. And if you could, it's probably hard to make out, but this is greenish appearing, and one of the nice things about microbiology as an advertisement is we like to smell things and look at things, and it's very colorful and it's a lot of fun. I think my fellow panelists would agree with that. We don't taste usually, though. So lots of bacteria. So this is the starting material that we were putting onto the inhalers. And again, what we were able to see is that even the mixed normal flora, so those white colonies and the strep that we were looking at, it killed everything. So the sputum was not protective. So this seemed to be a very, very effective way. So the CF Foundation was very happy with these results because they think this would be a very user-friendly and easy way to do this, and it seems to wipe out everything that we've tried. So the conclusion is that steam treatment is a user-friendly method to disinfect the home nebulizers. However, this was an in vitro experiment. So this was the laboratory taking the bacteria, putting it on, putting it in the machine and testing. The next step is what really counts, which is to use actual patient inhalers, culture them before you put them into the machine, and then culture them after, and try to decide if it really will work in the patient care setting. There's a couple of problems with what we did. Can anybody think of any? Am I allowed to do this during the session? Am I allowed to ask questions of the audience? Can anybody think of a problem? There's one big problem, if I can critique my own work. Yeah, go ahead.
Did the heat just kind of change the plastic?
Great question. So fortunately, so the statement was, did the heat change the plastic, and do they still work? Is essentially, And for not all of the nebulizers, but for at least 2 of the ones that we looked at, there's other people who have studied it beforehand and done like hundreds of steam treatments one after the other and showed that it's still able to get the medication across. But that's a great point, and as every new inhaler comes out with each new drug, you have to retest that. But we didn't address it, but others have addressed it. Anybody have any other thoughts? That's a great one. Yeah.
The study doesn't assess whether or not you change clinical outcomes?
Right. So that's a very challenging study to do. So the statement was it doesn't assess whether or not you impact clinical outcomes. And essentially the clinical outcome you'd want to look at is, can you keep kids out of the hospital? In other words, is doing this keeping kids out of the hospital because it's really making a difference in their infections or not? That's a great question, and I think to do that, you'd also need to compare it to some of the other methods that are out there, which the study didn't do either. So we didn't compare it to a dishwasher or to soap and water to see which is better. And the other thing we didn't do is that I showed you in the beginning, there's all these different bacteria that are out there, and we only tested 6 or 7. So there's a couple other big pathogens out there that we really need to know about before you can recommend this for routine use. But I think it's certainly a step in the right direction, and the early data look good. So we're in the process of trying to write up the informed consent and institutional review board for this clinical study, which is quite challenging. But the goal for this whole thing is really twofold. It's to reduce colonization to prevent hospitalizations for these children and to prevent infection. But it's really also about quality of life. So anything you can do to make it easier for them to take care of their home respiratory equipment and allow them to think a little bit less about the chronic illness that they have and worry a little bit less about something that they have to do related to their chronic illness can actually be quite beneficial to families who are dealing with chronic illness. And with that, I will stop and take questions.
We'll wait for the questions at the end.
Oh.
Thank you.
Okay, thanks.
Okay, so we're going to change gears a little bit and still talking about this concept of bacteria and viruses and what they do to our bodies when we encounter them. And in this particular case, my research interests have to do with the information that we receive from everyday sources, such as Oprah, such as looking on the internet, such as something simple as Google, is making a difference in how we're making our decisions about vaccinating. And we have about 1,500 surveys that we've completed so far. We're looking to get a much bigger number of looking both at people that have a science background and a non-science background at the student level and even at the faculty level. And the theory, the hypothesis that we're coming up with, and the data is starting to come in to prove this, is that a lot of our science and healthcare personnel have been influenced by Oprah just as much. They might know technically some of the information about a particular disease or a vaccine, but they actually have heard some of the same myths as other things. So a vaccine is basically something that we give to the body to be able to induce an immune response. And the hope is that by giving this altered or attenuated pathogen, that we're going to induce an immune response that later is protective. So normally we get exposed to a particular pathogen, a virus, bacteria, we get sick, and then it was noticed way long time ago that if you recovered from that particular pathogen and it didn't kill you, that you didn't get sick the second time you were exposed to it. And even back hundreds and thousands of years ago, the people who survived an epidemic were the ones that were left to take care of the people who got sick the second time. What we hope with vaccination is that we're going to kind of miss this step here. You get sick and potentially die or have some long-term consequences, and you develop immunity, and therefore the first time you get exposed to it, you have these nice memory immune cells, you have antibodies that are circulating around, and they basically are there preformed, and this memory is something that's huge to our everyday immune response. It's why we don't get chicken pox every time that we get exposed to the virus, and it's why vaccines actually work. So this memory can be varying both for a natural infection and for a vaccine-induced type of an immune response. Some last longer than others. And we've been very successful with our vaccinations. We know that we have eradicated certain diseases. So smallpox, we said it's gone. Humans are the only reservoir. We've been able to get rid of it. We're hoping that polio is going to be next. Humans are the only reservoir. We're very close to being able to come up with the same thing, that polio is dead. We have a few other diseases that are kind of coming down the pipeline here. The problem is coming because of the information that is there on the internet and so easily accessible on the internet, is that we're losing what we call herd immunity. So from the first vaccines that were available, people were very skeptical of vaccines. When Jenner developed the smallpox vaccine, people picketed and said we were to turn people into cows. I mean, this is not something new. What's new is the ease of information and the way we can contain that information and deliver it to each other. So what we basically have here is people here that are not immunized but healthy in the blue, people that are immunized and healthy, and then people who are not immunized and they get sick. And what we're hoping for is here, is that most of the population gets immunized, a particular pathogen comes through, and the spread of the disease is contained. And what we have is a few people here who are not immunized and are still healthy because we basically surround them and cocoon them, and we've created this kind of immunity. We know that there are lots of people that are immunocompromised, that are perhaps too young, they don't form immune responses, they can't be vaccinated, and so we're hoping that we can protect these people by kind of hiding them in the herd, and that if I'm the only one in here susceptible to a particular virus, and all of you have been vaccinated, you can't give it to me. But we're seeing that this has been reduced over time because now only some of our population is actually getting immunized, and we're seeing now that this herd immunity is decreasing. And infectious diseases are coming back, and they're coming back with really a vengeance. So why are we seeing some of these vaccine-preventable diseases come back? There's a variety of reasons. Not all of them have to do with the internet. Some of them just have to do with we can travel easier. So now we do have parts of the country, parts of the world, where there isn't the same accessibility to health care, and we now, a plane ride away, a disease can come through, and you might not even know that you were infected. A lot of these pathogens have an incubation period of 2 to 12 days. You get on a plane, you travel, you're now exposing lots of people to this pathogen you don't even know. So the world has just kind of gotten smaller, and that definitely plays a role. We know that no vaccine is 100% effective. So even if we did vaccinate every single person, that vaccine is not going to induce immunity in everybody. Same way as if we all got infected with something, not all of us are going to form an immune response, and some of us are going to die because we don't form that immune response. And we have that diversity built into our immune system. But we also know we have more immunocompromised patients walking around than ever. What has changed dramatically, we have transplant patients. We have now patients that are on autoimmune diseases. They're on immunosuppressive therapy. We have patients receiving chemotherapy. So we have a much larger population of people who are at risk and either can't be vaccinated, or if they are vaccinated, it perhaps isn't going to, they're not able to form a normal immune response and have that memory. So we need to protect them. We're hiding them in the herd. But a lot of the reason why this is happening is people are choosing willingly not to vaccinate. So why are they making this decision not to vaccinate? Part of it is the very success of vaccines. We don't see these infectious diseases as much anymore. In the 1950s, we had probably the utmost confidence in our vaccine program. When the polio vaccine became available, there were pictures of mothers lined up for blocks to get their kids vaccinated. They saw what was happening. When I asked people, how many of you know somebody who had the measles or died of measles, nobody really knows anybody that's had these diseases anymore. You know somebody that's had polio. So the very success has almost been their demise. But that skepticism that has been in effect since the beginning of vaccines has also come back with a vengeance. And we're seeing now the internet being used in anti-vaccine purposes. So we have now here nice scabs on the person's hands who's giving the vaccine. We see death and autism as a result of getting vaccinated, always crying kids in the pictures. There are no safe vaccines. And how does a person, a parent, wants to do their absolute best for their child? How do they make the decision of what's fact or fiction? Immediately you put something into Google and we're believing what we see when we get those results back. But we have to be consumers of knowledge. We have to be discriminatory in what information we believe and we don't believe. So we've been doing surveys, and one of the surveys was just simply, can you get the flu from the flu vaccine? And at any point in a semester, I usually have 15 or 20 students working on vaccine-preventable diseases and educating the public with me. Some of you are here. And one of the questions we asked simply was, can you get the flu from the flu vaccine? This is very interesting, about 1,500 people. We have about 2/3 of the people who either aren't sure or believe that you can get the flu from the flu vaccine. So I had my students all go out last flu season and ask their pharmacists. Big signs now, get your flu vaccine shot here. And the pharmacists who are delivering these vaccines really didn't know the correct information. And one of my students has an 11-year-old daughter. She went to the pharmacist and she said, tell me about your flu vaccine program. And the pharmacist said, it's very good, I highly recommend it, but we don't deliver it to children under 18. She said, well, can you tell me why? Because if you're under 18, you can get the flu from the flu vaccine. Now, even if that was true, what happens at 18 that miraculously changes that? But her daughter, who's 11, said, no, you can't. I get the flu vaccine every year, and I've never had the flu, and I've never gotten the flu vaccine. So in this particular case, someone who was administering this vaccine and giving information out didn't necessarily know the true facts about this. When we went further with this survey, and we actually now asked people, do you know somebody that got the flu from the flu vaccine? Now all of a sudden, the number got a little bit smaller. So we've heard that you can get the flu from the flu vaccine. Do you know somebody? Did you ever get the flu from the flu vaccine? So now that number shrinks a little more. It starts to become apparent that we've heard a lot of these rumors, just the same way we get an email saying, go out tonight because Mars is bigger than the moon. We all go, oh yeah, and we're going to forward that to everybody, and then you think about it, and no. But we do. We fall into that kind of a trap. So we do not have the ability to get the flu from the flu vaccine, but people have circumstantial evidence that that happened. My brother 3 years ago called me up and he said, I got the flu vaccine yesterday, and see, today I got the flu. I said, even if they injected live virus into you and forgot to inactivate it, it doesn't happen that quickly. There's an incubation period. And then a lot of people say, well, how do I know if I've ever had the flu? I ask my class this every year. I say, how many people know you've had the flu? And a few hands go up. And then I say, how many people aren't sure if you've ever had the flu? And most of the people raise their hands. I say, if you're really not sure if you've had the flu or not, you haven't had the flu. Because if you've had it, you really know that you've had the flu. You feel like a train ran you over, and you really know it. But the vaccine contains inactivated virus, so you can't get the flu from the flu vaccine. It's just not possible in there. But yet we see these myths of all these terrible things that can happen to you appearing on the internet, and mothers are scared. They want to do the absolute best. And they say, even if there's a small risk, even if this is possible, well, how often do I see measles or polio? I'd rather take my chances, and it's a weird, rare disease. You don't see anybody having it, rather than, oh my God, look at all the terrible diseases that this child can get, and they show poisons and they show all this stuff on there. But we know what happens when we stop vaccinating. When the Soviet Union demise with their economy, we saw with a vengeance some of these diseases came back. Okay, but that's the Soviet Union. That can't happen here. And yet we see it happening here. We see headlines of vaccine-preventable diseases coming back. We see outbreaks. And this information is available to us, but we still kind of make the decision of it's scarier to think about what could happen if I give my child that vaccine versus, oh, it's really rare, it's going to happen to somebody else. Or my child will be the one that hides in the herd. I'm relying on all the rest of you that you can take your chances with what happened, and my child's going to be protected. So we start to think about this, and we believe in this country about freedom. And this quote I really like when it comes to vaccines. It's, I absolutely have freedom. I have a couple of politicians in here later on, and it's a touchy subject with politicians because we're going to mandate vaccines. We saw what happened in Texas when we tried to do this. So the freedom of my body and my ability to do what I want to do ends when it hits your face. So we have now a vaccine-preventable disease that when you're not getting yourself vaccinated or your child vaccinated, you're not just affecting yourself or your child. You're affecting everybody that child comes in contact with. So we are seeing things like, say, tetanus. If all vaccine-preventable diseases were like tetanus, I wouldn't probably be having this talk, and I wouldn't be having the students do this research. Tetanus is definitely a terrible disease. It still kills a lot of people. But tetanus is different than all the other vaccine-preventable diseases that we talk about in that it is not contagious. So if I don't get vaccinated against tetanus and I get tetanus and I die, that's sad. If I don't do it to my child and my child dies, maybe you can say I'm neglectful, but it ends there. With all the other vaccine-preventable diseases, that decision not to vaccinate now affects everybody that a child comes in contact with. The measles virus can hang out into the air for 3 or 4 hours. So you bring your child into the doctor's office. They just kind of not feeling well. They have flu-like symptoms. They don't really have all the symptoms of measles yet. And then a mother brings their 6-month-old baby in next. Or the nurse has rheumatoid arthritis and she's immunocompromised. So now we're affecting all the people that child came in contact with. It's not so limited anymore. And we know that we're seeing problems as a result of parents not vaccinating. And it's almost gone so far as, could you accuse that parent who didn't vaccinate their child and another child who died as a result of it of neglect or of a crime? We know that when HIV was popular and new, people were going out intentionally infecting other people, and they were kind of tried for purposely transmitting a lethal disease. In this particular case, could you charge a parent because you have now that child going into a classroom and that teacher is pregnant, doesn't realize that there's unvaccinated children? We don't have access to that information here. Say there was an immunocompromised student on our campus, and we wanted to know, were the students that that student is dorming with in their suite, were they one of the ones that didn't choose to get vaccinated? And now you have somebody that's immunocompromised and is very susceptible, and is that person at risk from coming in contact with that other person? So yeah, we have that freedom to choose, and it's our own medical care, it's our child's medical care, but we're now affecting the rest of the world. And what's happening is these websites are now appearing to say, well, this could actually be a crime. So Jenny McCarthy is a Playboy bunny who has deemed herself an expert in vaccines. Celebrities have now jumped on the bandwagon, and they are followed with increasing popularity. So this particular website is anti-Jenny, and what they are trying to say is that this is the number of people that she has harmed and killed as a result of her anti-vaccine movements. So yes, it's extreme. You're probably not going to be able to bring this up in a court of law and accuse her, but it gets to the point of there are people now that are very upset because there are websites out there that you can go to and say, I don't want to take my child to a doctor who requires vaccines. And there's a list of doctors. But what if you're the other parent and you don't want to take your child to a doctor who will accept patients who don't vaccinate because you don't want to put your 3-month-old child at risk? There's no website for the opposite. So the anti-vaccine people seem to have more energy and more time to be able to get on the internet and do things on the internet. So I found this a couple of days ago. I thought this was extremely interesting in that what Scientific American partnered with Science Debate, and they came up with 14 questions that they thought that the political candidate should be answering. And I was really pleased to see that vaccines was one of the top 14 science questions that they were asking. I thought, this is great. So they asked a very important question. They wanted to know, what actions would you support to enforce vaccination since it's in the best interest of public health, and under what circumstances should exemptions be allowed? This is the perfect question to ask our candidates, except neither one of them answered the question. Obama said, we need to make sure everybody has health care, our bill is really important, and we're going to make sure everybody gets what they need. That didn't answer the question. And Mitt said something about, we need to make sure that America has the workers and the factories and the science and the innovations, and we need to stop this from going overseas. And that didn't answer the question. So I was kind of excited that this was one of the top 14 questions that was being asked, but very disappointed in that they completely missed addressing the question in any way, shape, or form. And there is a link on here to their full debate. I just took out a few sentences from there, but there's nothing in either side that actually addresses the question here. So we live in a wonderful age. If I asked any of you right now what is interleukin 23, you probably have a device on your body and you'd be able to tell me what it is because you have some kind of smart device on you. So we live in a world of Web 2.0. We have the ability to author websites now. We have the ability to change information on the website. It is a very different world than my mother bought the World Book Encyclopedia from a little traveling salesman that used to come around, and I read the whole encyclopedia set, except my brother stole the E, and I never got to read the E, and it was very upsetting to me. And now the information that's out there is instantly updated. You can go onto Wikipedia today, and you can change that information. That's awesome. It's great. What's in your refrigerator? You can actually come up with a recipe based on what's in your cupboard in your refrigerator. It's interactive. People are self-diagnosing with a scary degree of accuracy in some cases, and they're coming up with to the doctor of saying, I think I have this because I put my symptoms into WebMD. So the world has changed. We don't need to know code. We don't need to understand programming. We can now, I maintain 7 blogs. I don't know any code whatsoever. I don't have to maintain a blog. It's very easy for us to author now versus before companies owned the internet. So this is a short little 50-second video which I hope plays. We use the internet for absolutely everything, and it has even gotten to the point now where Google has published a paper And this paper appeared in Nature saying that Google, when you type in your symptoms, has the ability to track influenza, the flu, better than the CDC. So what happens is you go to the doctor, they're not sure if you have influenza, they have to send the sample down, they have to do the testing, it comes back, it takes a few weeks. In the meantime, you've typed in your symptoms, and what we've actually shown is that the CDC is accurate, but it's 2 weeks behind just people entering their symptoms in. And you can track this in different countries, in different times. You can look at the United States, and the curves are exactly the same, except Google is 2 weeks ahead of the CDC. No matter what country you look at, the curves are exactly the same in here. So we're now self-diagnosing with a pretty scary degree of accuracy. So this was something that was actually published in Nature, and there's been lots of information now done on Google Analytics and the ability of what we put into those search engines to be able to change the world. If you have an infectious disease, your dog gets rabies, you come down with West Nile, you can now go on to Health Map and you put a little pin in, and you can actually track real time, with no verification, but real time, what diseases and what infections are happening where. So here's Connecticut here. I looked on this, and there's little outbreaks near me, and you can actually submit an alert. You can actually put in, is there an outbreak missing? Because you happen to know of something. Is there influenza near you? And when I pulled up the information near us, we had a measles outbreak in New Paltz, and I grew up about 10 miles away from New Paltz, so this was quite interesting that that was what popped up. We saw that there's whooping cough in New York and Connecticut. We also could see things like the beaches are closed due to, fecal contamination. So the internet is changing, and it's easy for anybody to get a website and to be able to do this. Look at this, in 30 minutes, no experience necessary, pick a design, make it yours, publish it, $9 a month, and you have a website. You don't have to know any code, you don't have to know any programming, and you have a website. And people are doing this, and they're now being very active. And these parents really believe that their children were damaged by vaccines, and they have the energy to carry this out. And unfortunately, the internet is really changing parents when they're now looking up, should I vaccinate my child? They want to do the best for their child, and they're getting all kinds of erroneous information, and they can't tell good information or bad information, so they're really confused. There's not a lot of good resources out there. They go to the doctor, and they go to their PA, and they basically are kind of told, yeah, vaccines are good, but they want to know, wait a minute, I've heard there's formaldehyde in vaccines. They want to know, I've heard of immune overload. And they necessarily can't answer the questions. They know vaccines are good. They know they probably don't believe that they're harmful. They don't necessarily believe some of the myths. But maybe they heard something on Oprah and they're not exactly sure, or they didn't spend the time to research what is immune overload and how can I explain this to a parent. So we're seeing sometimes that healthcare personnel can't answer the questions, and some of my survey is looking at science and non-science majors and healthcare versus non-healthcare personnel, and looking at how people are using the internet, and that we go to Google, the first thing that comes up is that low-hanging fruit, that's what we grab, and the things that come up with those hits are usually anti-vaccine propaganda in there. So how do we be a consumer of knowledge? How do we know what's real or not? So I put in Bigfoot, and I got 22 million hits of Bigfoot. So how do I decide, is this real or not? Well, there's pictures of them, so it's got to be real. There's a guy that have him in his freezer in Maine, so it's absolutely got to be real here. So this is Bigfoot sightings in the New England region. We've got, all right, it's not a million, but it's still a fair number of people who think that Bigfoot might be in this guy's freezer. And I mean, there's a picture of him, he's got to be real, right? So how do you discriminate between good information and bad information? How do you know what's true and what's not true? Well, once we get to science news, it's got to be true then, right? So now we're going to something, yogurt is killing. And we see this, that, oh my God, yogurt, potentially good bacteria, killed 24 people. Probiotics may not be as innocent as we claim. One of my graduate students actually posted this on my discussion board, and everybody started talking, oh my God, I eat yogurt, we should stop eating yogurt, is this bad? Oh my God, what's going on with this? It's got to be real. Look at the number of people that were Googling this and looking at friendly bacteria linked to 24 deaths. When you investigated this a little bit further, you definitely saw a lot of people jumping on the bandwagon. It went viral, so to speak. And things go viral all the time. This little squirrel appeared in the picture. This couple was on their vacation. They set up the camera on the rock, and the squirrel jumped in their picture. So now there's a whole website devoted to this squirrel. You can follow him on Twitter. You can put him in different pictures. He's appeared with the president. He's appeared with Tiger Woods. It went viral really fast. And information does go viral really quickly. So the study on yogurt was something that was true, but it was done in people that had severe acute pancreatitis, and it wasn't people eating yogurt. It was given basically through a stomach tube for 28 days, and it was true that more people in the group that got the probiotics died than in the control group. But the way the press portrayed it was that yogurt was killing people, and people stopped eating Dannon yogurt. So it was very worrisome. YouTube. One of my research projects is all my students are creating videos, and they actually have to do a 5-minute public service announcement and put it up on YouTube to be able to help level the playing field. So this paper appeared in JAMA, and it reflected on the fact that when people go into YouTube and they're trying to get information out there, what information is anti-vaccine and what is pro-vaccine, and there's much more information out there that's anti-vaccine. People are much more likely to watch it, so they've done analysis on there. So my students are actually going forth and putting forth videos that the public can actually watch to be able to get some correct information and have it be entertaining at the same time as informative in there. But we know there's a lot of bad information. Desiree Jennings was supposedly hurt from an influenza vaccine. She was completely debilitated to where she could not talk or walk, except if she ran. She talked and ran fine. So there were things about this that were kind of odd, but this appeared in Inside Edition at 7 o'clock, and I must have gotten 1,000 emails when this came out. Oh my God, look, the flu vaccine is really bad. They followed up a little bit later, and they saw her walking out of a supermarket, and until the camera saw her, she was kind of walking just fine. She was later diagnosed as kind of a dystonia. She probably wasn't faking it. She probably had real symptoms that was inducing some of this paralysis, but it certainly wasn't induced by the flu vaccine. But a lot of people saw this on prime time and on YouTube, and that was a real problem. So how do we separate fact from fiction? These websites say really bad things out there. It's absurd to give a disease to a healthy person. It's like having a child have a small rape in order to provide them for a larger rape. That's the analogy that they're making to a vaccine. So you're a parent, you're going, oh my God, I'm never going to give a vaccine to somebody. So we see here, I like number 2 especially. Vaccines are really microchips, and they're designed to facilitate mind control or to track you. And there's people out there who really believe this. So how do you level the playing field and kind of come to this? Vaccines are biological weapons. The theory on microbes is false. Pasteur was an imposter. Because of their neurotoxic effects, they produce psychopaths. My God, I'm certainly not going to give this to my newborn child. So how do we discriminate between good information and bad information out there? And it's one of those things that we want there to be that information out there for healthcare professionals and for parents who really want to make that informed decision. They want to do what's right for their child. So we want to be able to create some of that information. The CHOP website, Children's Hospital of Philadelphia, is one of the few websites that will actually explain a hot topic, explain a myth, and then debunk that myth. So some of what the students are doing is kind of looking again at healthcare professionals to non-healthcare professionals, science majors and non-science majors, and the data that's coming off is saying that there's really no difference or very little difference in the myths they've heard. They've all heard Oprah, they've all heard some of this information, and they're worried about that. So it's our responsibility as a scientist to help to be able to understand what's fact and fiction and to help be able to explain to people what's really going on with that. So I'll end with that and let David take over.
Okay, so thanks for the opportunity, and Lisa's presentation was a clear lead-in to this, without a doubt. And I'm going to use measles as a paradigm of vaccine-preventable diseases and the challenges that we have in controlling vaccine-preventable diseases on an individual, on a community, national, and global basis. So this is the face of measles. Maybe most of you in the room have not seen this. Those of us who are older had this face, and certainly have seen our many of our patients with that. An unhappy child with a classic macular papular rash. Well, what is measles? Measles is a viral illness, a paramyxovirus, which Tom can explain better than I, but it has RNA genetic material rather than DNA, and it has a single antigenic type. And so that's helpful in terms of thinking about a vaccine, as there aren't lots of different measles viruses out there. We can make a vaccine to one measles type, which will be effective, unlike trying to make a vaccine for HIV or some of the bacteria that constantly change. How do we get measles? Well, we inhale respiratory droplets. So somebody else is blowing their nose or coughing and spewing that virus out, and then we're in close proximity and inhale that. It replicates in our nasal and oral passages, and then it goes through those into the lymph nodes of the head and neck. Following that, we have a primary viremia, i.e. the virus gets in the bloodstream 2 to 3 days after exposure, and then there's a secondary viremia after the virus multiplies a bit where it infects the tissues, and that's when you're getting the rash. So measles is traditionally known as the 4 C's. When you're in medical school, you always try to put these monikers to diseases. The 4 C's here are cough, coryza, conjunctivitis, and Koplik spots. Koplik is actually a K, but we pretend it has a C, so we can remember it. So an incubation period, if I'm exposed to measles, I'm not going to become ill for a week or 2. Then I'll have a prodrome, i.e. I'll have a non-specific illness before the illness manifests itself. So prodrome of fever, malaise, meaning feeling poorly, a cough, coryza is kind of a snotty nose, and conjunctivitis, inflammation of the lining of the eye. And then the rash begins 2 to 4 days after the prodrome, so this is when the classic presentation of measles. So as Lisa was saying, there could be a child with measles in the room for a few days. Nobody would know it was measles, but then they come down with the rash. And then they have the Koplik spots, which I'll show you a picture of. People are infected 4 days before to 4 days after the rash. So infectivity, excretion of the virus in the secretions occurs before measles is obvious to a physician or to a parent. And overall, it lasts about a week to a week and a half. So again, here's another face of measles. This is an unhappy, miserable kid with a classic macular-papular rash, meaning macular is flat, papular is slightly raised, red, confluent and joining together, with a snotty nose, their mouth is open, they're coughing, and their eyes don't show up so well here, but it's red, and you can even see some kind of secretions from the eye. A very unhappy kid. These are the Koplik spots, so they're like little grains of salt or sand inside the mouth, so these little white spots. So this is the 4th C, cough, coryza, conjunctivitis, and Koplik spots with a K. So we think of measles and say, oh yeah, measles was a disease that was there, and everybody had it, and we all survived, but those of us who didn't, or those who didn't survive aren't talking about it. Measles is not necessarily a benign disease. So if you look at large populations that have measles, about 30% have 1 or more complications from measles. Some of those are diarrhea, middle ear infection, pneumonia. Pneumonia accounts for most of the deaths from measles, so getting measles pneumonia is a very bad thing. A large percentage, up to 20%, are hospitalized. If you're pregnant and have measles, you have premature labor, perhaps miscarriage. You can get encephalitis, meaning inflammation of the brain, like we're talking about West Nile encephalitis now. Well, measles is another virus that can cause encephalitis, not commonly, but can. And then there's a late complication of measles infection called subacute sclerosing panencephalitis. And UK data, I spent the last decade in the UK, so I have a lot of UK data. About 1 in 5,000 children or adults with measles will die. So that presents it as a slightly different picture than an everyday childhood illness. And if you're in a low-income country where vitamin deficiencies may be relatively common, you get measles, you can have blindness, and what happens is this very unusual and disconcerting process that the cornea actually melts. It literally melts, and then it leaves you a scar when that heals over, so you're blind. And that can happen within hours. Very unusual thing, and you can give vitamin A, and it reverses very quickly. But if you don't have vitamin A, that can lead to what is an easily preventable blinding disease. Lisa mentioned how infectious measles was and is. So this is a study, 25 or more years old now, that was in pediatrics. Case of a 12-year-old with measles who was coughing vigorously. He just transited a waiting room, so his mother probably walked him through the waiting room in a pediatrician's office. and he was in the examining room for an hour. There were 7 cases, which was 80% of those unvaccinated in the room. So of the 100 or so people in this room, if I was in here for a short period of time coughing up measles virus, you were unprotected, 80 of you would come down with measles. That is an incredibly infectious disease. 4 transit contact as he walked through the waiting room. 3 had no direct contact but arrived 1 hour after the child had actually left the room. So the measles virus is kind of floating around in the air. So we call this an RO of 15 to 20. That means a single patient with measles will likely infect 15 to 20 other people who don't have measles or haven't been vaccinated. That is probably the most infectious viral illness out there. Tom, is that fair to say? It's pretty up there, much more infectious than flu. Flu might be 1.5 to 2.5, so each case of flu might infect 1.5 to 2.5 other people. So this is a very efficient virus. So let's put it in the context of the world. This is a website that's well worth going to, worldmapper.com. This is the world by land area, and the next slide is the world by vaccine preventable deaths in 2002. And you can clearly see that countries of the world in low-income regions suffer the most from vaccine preventable disease. Fortunately, this is a decade old, and the continents, Indian subcontinent and Africa, wouldn't look quite so fat, but still this is a huge issue, and measles still is a major contributor to the global vaccine preventable disease burden. So to address this, many international bodies have dealt with this issue for decades. This is the Global Immunization Vision strategy from UNICEF and the WHO. Immunization is a cost-effective and life-saving intervention which prevents needless suffering through sickness, disability, and death. All people without distinction of race, religion, political belief, economic, or social condition have a right to equal access to the needed vaccines and interventions. So now it's just to implement that. So if we look at measles in this context of global vaccine preventable diseases, there's a very nice curve between vaccine coverage, whether you look at WHO, UNICEF, or official coverage data, and the decline of measles cases. So we're going from millions of cases down to hundreds of thousands or less. So vaccine institution has been very important. And unlike other diseases where incidence in tuberculosis is associated with improved sanitary and living conditions, measles is really associated with vaccine implementation because it is such an infectious disease. But there remain pockets of measles, and it's not just here in Africa. So this is numbers of cases, not case rates. The darker you are, the more numbers of cases. You can see Africa, the Soviet, or Russia, China, Southeast Asia. But look at Europe, and so we're going to focus on Europe. Europe, well, I could say Europe is a rich area, but having lived in Europe for the last decade, there are plenty of challenges now with the European economies, which make the U.S. problems look like a piece of cake. But let's look at the incidence of measles in Europe for the year 2011. So this is a area that has most of the resources necessary to institute vaccine preventable programs. 30,600 cases, and this is case rates here by the color. The darker you are, so France and Eastern Europe here, more than 10 cases per 100,000 population. If we look at France, a rich country by all standards, 15,000 cases, okay? 16 cases of encephalitis, 650 cases of pneumonia, 6 deaths, and an incidence which is really very, very high of 23 cases per 100,000 population. Now this has to do not with the internet so much and people's individual choices not to receive vaccine, but more the failure of public health programs to reach all the marginalized communities that live in France. There are a lot of called traveler communities, which you might call gypsies, that just shun typical exposure to public health programs. There are lots of religious communities who don't necessarily have a feeling against vaccines, but just can't get their 10 kids, Hasidic Jewish communities in urban areas in France, to doctor's offices for vaccination. So that it's not so much people's individual choice against vaccines, it's the failure of a modern public health system to reach all the citizens who are residents of a country. This is the graphic that describes those cases for the first quarter in 2011. And they're, well, what do you see there? What is this graphic saying to you in terms of the cases? Not necessarily where they come from, because France in red dominates that. But what do you see there? So you have case numbers here and age here. Okay, so this is occurring in older individuals. So we're thinking about, well, even beyond college, 20 plus. So we think about measles as a childhood illness. We think about childhood vaccination for children getting measles vaccine at age 12 to 15 months. So why are all these adults and adolescents getting measles? Is the vaccine no good? Are they not getting vaccine? Does the vaccine wane? Does protection wane over time? What do you think? Yes?
They didn't get the vaccine as a child.
So they didn't get the vaccine, and that really is the issue here. So 80% were over the age of 5, and 84% were unvaccinated. So again, these were oftentimes not personal choices, they just weren't in communities that were being reached by public health campaigns. So if we kind of look on a parochial basis, I always like to look bigger, and the US kind of seems small when I focus down on it, but if we come back to the US, these are measles cases over the last decade and a half plus. In red here, you can see they've come down nicely, but as cases have come down in the US, the percentage that are related to importation, so an imported case, someone comes from a different country, comes here, develops measles, but also cases that are secondary to those importations has increased, so we're up over 90%. Now, measles was quote-unquote eliminated in the United States in the year 2000. That means we didn't have circulating measles viruses in this country causing consistent cases, epidemics, outbreaks year after year. So basically, measles now is related to importation. So it's all those other countries, we can be very xenophobic if you'd like to do that, who are bringing this back into our country. If you look at the cases, it's much like the cases in Europe, in that in the grayish bar here, these are unvaccinated. So basically for nearly every year, most of the cases, 80%, 90% or so, are in unvaccinated individuals. Now if we focus this down, we're only talking about a few cases. We're not talking about 16,000 cases in France. We're talking about a much smaller cases. So it's a number we can handle, and we can get back to what Lisa was talking about. This, for a 4-year period of time, 2008 through 2011, these are reasons for non-vaccination in U.S. residents. And you can see religious or personal exemptions. So you do realize that you have to have measles and mumps and rubella to go into primary schools, but you can take personal exemptions. So basically 3/4 of these were religious or personal exemptions in the younger children. A missed opportunity, meaning they weren't reached by the public health system. They should have been vaccinated, but for some reason they never were. Other unknown, and intentional delay. Some people like to delay until the child is older. So many of these cases, up to 80%, have been a decision, oftentimes by a parent, not to vaccinate their children. If you look at older individuals who are getting this, there's a philosophical objection to vaccines. So this is where the personal choices are impacting the public health system. So this is a situation in Indiana of a measles outbreak related to an eager young person, a teenager who went to Romania to do good, to work in an orphanage there. She was doing it for religious reasons. She came from a religious sect that didn't get vaccinated. So she came back to tell all of her fellow people, friends, adults, others, about her experience. So here was the gathering. This is the index case, this teenager who went to Romania, developed measles, but she was in the prodrome. She didn't show up with this bright rash and a snotty nose and all that, but she was probably coughing fairly vigorously. And in this room of 500 people, there were 50 who were non-immune against measles. So we see in the perfect incubation period, so if you're thinking about epidemiologic studies, you can see exactly, here's the incubation period for exposure to measles. So on the 16th, she spoke, and beginning on the 26th or so, 10 days about there, people were getting cases there. So 19 cases after that. And then you're beginning to get some secondary cases. So these 19 went and exposed other people. So 11 cases. And then even you're getting cases out here, kind of tertiary cases, meaning third in the cycle, 2 cases. Not a benign thing. 16 had diarrhea, 2 had a middle ear infection, 3 were hospitalized. It had a huge public health burden, which $170,000 to contain this outbreak. Involved 99 public health officers and 12 health departments. So an individual's decision, and probably she didn't make that decision, probably her parents had made that decision, but a family's decision not to vaccinate created this epidemiologic situation which is repeated time and time again in the US and other countries. So I don't like to get personal, but having spent the last decade in the UK, I can't talk about measles and personal choice and objections to vaccines without talking about Andrew Wakefield, who looks very professorial here. He was a professor in pediatrics. I don't think he actually was a professor. He was probably a lower grade there, maybe assistant or associate professors at the Royal Free Hospital, which was just 5 miles from where I spent the last decade. And he was looking at the association of bowel disease, measles vaccine, and autism. And in 1998, he, with several other eminent investigators, published a study in The Lancet which says that we have identified a chronic enterocolitis in children that may be related to neuropsychiatric dysfunction, i.e. autism. In most cases, the onset of symptoms was after measles, mumps, and rubella immunization. Based on a very small number of children, it was 12 children. He held a press conference as this study was done, and the floodgates opened after this. England, as opposed to the United States, is ruled by basically 4 newspapers. There are two pretty liberal, one mainstream, and then actually more than 4, and then there are several what we call red tops or rags, which are very kind of anti-government, anti-authority. And so they just picked us up and ran with it. And because everybody reads the same newspaper, they're not, some aren't reading the Haven Register, some reading the Hartford Courant, some reading the New York Times. They're all reading the same papers. And so it just took over a country of 60 million. And it was fueled by Tony Blair dithering. He didn't dither about the Iraq War, but he did dither about whether or not his son was going to get MMR. So this was going back and forth. Has Leo gotten MMR, or hasn't Leo gotten MMR? Has he or hasn't he? And finally it came out, this major news in The Independent in February of 2002. So this is 4 years later. It's still percolating. It said that he got it. But look at how the uptake of the MMR jab is fall down to 84.2%. So we need measles coverage of about 95% to protect a population to develop that herd immunity. And so the UK had a very nice decline in measles notifications with the institution. So the UK was unusual in that MMR vaccine was not universal policy until 1989, much later than in the US, which instituted various measles vaccines in the 1960s. And so you see over the 25,000 cases coming down to maybe 2,500. But in 1998, look at the measles uptake here, falling way down below 80%. And this is a long time to do this. So having sat on the national vaccine panel for the UK, every single session we talked about how are we going to increase measles coverage in unreached groups. This affected the whole vaccine program, the whole profile of understanding of vaccines for an entire nation, and took a decade to reverse. Now there are obviously other things that are coming into play here, but still important. And England is still dealing with this and other issues. There are many unreached populations in the UK. just for half a year, they've had 2,200 notifications so far. And rather than being a country that did not have measles, it became like many low-income countries, and Europe declared measles endemic in the UK in 2008. So the UK is no different than many countries who don't have the resources to institute vaccine programs. This, make a long story short, 12 years later, through a lot of processes, through 8 of the 10 authors retracting the paper, but not Andrew Wakefield and one of his co-authors, through him going through the General Medical Council and being struck off. This was retracted by the Lancet in 2010, because not only was it poor science, but it was unethical. The children were recruited inappropriately. The controls were never controls. He was being paid by lawyers. They were bringing lawsuits against manufacturers. So it's a pretty ugly story, very well written up in the British Medical Journal last year. So this, if you went to Lancet, you could not find this paper anymore. I have a copy if you want to. I'll send it to you. So measles still with us. It's a disease only of humans, and it's a safe and effective vaccine, highly effective vaccine, and it is a safe vaccine. Why is it still with us? It shouldn't still be with us. It can be eradicated, like Lisa pointed out with smallpox, and as polio will be, hopefully by sometime next year. There are challenges of delivering national immunization programs. There's an inability to reach certain groups, and there's this conflict of personal choice versus the public good. And how do we rationalize that on an individual basis as well? But certainly our goal for measles and all vaccine-preventable disease is to have a long string of very healthy and happy kids. So I'll stop there, and thank you for your attention.
So I'll invite the 3 speakers to come up and be a panel, and we'll open it up to questions in about 15 minutes. So, and if you would just repeat the questions that the audience has. So who'd like to start us off? Questions? Debbie.
Does anybody know what Quinnipiac's policy is on immunizing of students? And I know you have to submit records, but what happens if you haven't gotten an immunization? Is anything happening? Anybody know that information? Or just colleges in general?
Well, there are a list of immunizations that all students would be required to have, but I'm sure if you have there are personal exemptions for those. I don't know how often that occurs. I don't know how that's handled in the health center, but we rely upon a high level of immunity within a community, as Lisa was mentioning, to protect everybody. So if you had 1,000 students who chose not to be vaccinated, we'd be on the front pages of the newspapers sometime in measles season with a huge outbreak.
Is that going to be any different, do you know, for the medical students coming in, given that they're higher level of potential exposure? Can you require any differences? Or nursing?
We have our dean here.
In our, I can speak for our PA program because that has been more documented. The issue is there that they have to not only prove that they've been immunized, but that they actually have a titer, which is very different because they have to go out into, the pediatric population and, the maternity and, so not only do they have to prove they've been immunized, but that immunization actually has to take effect in them. So I don't know with the medical schools. We actually do have a student who's coming through our pike that will be taking microbiology and pathogenic, and she is severely immunocompromised. And there has been a lot of talk in our department over safety in the laboratory. My issue was more safety in her dormitory and safety in her classroom. And when we tried to contact the health center to find out, could we ascertain if somebody in her class was unvaccinated, we were not able to get that information. So.
I have a question. I'm old enough to remember measles and having measles, and one of 5 children who had measles in the house without any adults catching it. Is it a childhood illness, or are we going to see adults who haven't had vaccines developing measles in the next 20 years? In the past.
So highly infectious diseases such as measles, become childhood illnesses. And you're protected generally from your mother's antibodies that circulate in your system for about 6 months to a year after you're born. And then you are susceptible to measles. So you'll see measles when children begin to congregate together as unvaccinated populations. So it usually was around school age, 3, 4, 5, whenever you're going off to school. So with a highly infectious illness, then everybody gets that illness at that young age, and so your adults are no longer at risk. They're all immune. But as vaccine-preventable diseases decline, you see an increase in age of those who are coming down with illness. And there are lots of different paradigms as to how that can happen, and there's an issue with pertussis now because in that situation adults, they're having waning immunity from their pertussis shots, and there's a lot of pertussis around, whooping cough. So, but typically highly infectious illnesses are diseases of children.
If parents are going to choose to not vaccinate their children, shouldn't it be public knowledge then as to who's choosing not to vaccinate their children so that people aren't at risk?
So,
I'll let Tom take that one.
So from a pediatrician's point of view, first of all, it's your practice, so you have the choice as to whether or not you want to care for children who aren't vaccinated. So that's a choice that every provider makes, and different pediatricians have different approach. This country has decided that personal health information is personal and private. So it is illegal to disseminate that kind of information to anyone without the written consent of the parent. It's pretty clear on that.
However, there are lists of pediatricians who don't require vaccinations,
Right.
but the opposite list doesn't exist.
That is correct.
So it would be nice if parents who do want to see a pediatrician who won't take on those patients
Right.
would have a list that they could then go to.
Absolutely. And one approach to that is many practices will have a pre-baby visit with the expectant mother, where the family comes in prior to the birth of the baby to discuss exactly what it means to be a part of that practice. Who's on call? Do I see my regular doctor? Do I see whoever's covering sick patients? And part of that conversation can certainly be, do you accept patients who aren't vaccinated? And as long as it's global and not referring to specific individuals, that's completely appropriate. Mm-hmm. So if a pediatrician's not telling you, that's not a good pediatrician. It shouldn't be a secret.
So I'm wondering how you're, in your thoughts for your future studies, sort of like embedding it into the everyday lives of your clients, of your patients. I'm wondering if you could talk a little bit about that.
Sure. So there's really a couple of different aspects to the study in terms of primary outcomes and secondary outcomes. So the primary outcome of the clinical study is, does it work? So if you take an inhaler and you culture it for bacteria before, and you treat it and you culture it after, do you get rid of the bacteria or not? But then a secondary outcome could be, how often do they clean it compared to whatever method they were using before, and what impact has it had on their activities of daily living. There's a huge push in the CF community that I think is reflective of many communities around patients with chronic disease of, as more and more treatments become available, it becomes more invasive to being a normal individual. So children with cystic fibrosis, between the pills and the inhalations that they do, can spend 4 to 6 hours a day just taking medications, which is a lot. And some of them can take many, 6 to 8 pills a day too, in addition to the things they take for digestion and other things. So any kind of intervention that you can do to take anything away and make anything faster or easier, it might seem like a very small intervention, but it can actually have significant outcomes. So you could look at compliance and whether or not they're actually washing them at all.
I have a kind of touchy question. As professionals in healthcare, do you think we should pay for their medical bills if they're not being vaccinated for these detrimental diseases?
I mean, I guess it's the
As
same
an altruistic
as-
society, I think we have to pay for
Yeah.
people who don't always take care of themselves, whether we pay for the consequences of chronic alcohol use or injection drug use or
Automobiles.
psychiatric care or riding a motorcycle without a helmet. People do lots of things, make lots of choices throughout life that cause bad things on themselves and we tend to pay for that. So we need to ramp up our ability to communicate the healthy messages. And so part of our healthcare should be not just letting all these people do these things, quote unquote, but trying to develop ways to reach them, to give them the best messages about how to be healthy. But it would be a pretty draconian society if we turned them away.
Right, and the other way to think about it is not to punish people who don't do certain things, but to come up with rewards for people who do. So maybe you reduce the insurance rate if somebody does wear a motorcycle helmet, or if they choose to get their full vaccinations, you come up with some sort of benefit for them as opposed to trying the other approach. So I think anything to promote healthy behaviors is the way to go.
Part of the dialogue with the Affordable Care Act, which is known by its pejorative term as Obamacare, is that insurance might be much like car insurance. So every time you apply for your car insurance, your rate is determined by your experience as a driver. So if you've been a safe driver, how many accidents, how old you are, et cetera, who else is going to be driving the car. And so maybe you could do health insurance much the same way. And you'd have to have a cap for those who are extremely ill, but those who are more healthy might pay less, and you could shop around for a cheaper policy.
Nowadays, they have a nasal spray that they use for flu vaccines, and they do it for kids. Is there a reason that they started doing that? Does it work better, or I'm just curious on the shot versus the nasal?
So to repeat the question was about the nasal spray influenza vaccine, which is available. So a couple of things. First of all is that it is a little bit, there's some studies, you can find studies either way in terms of its effectiveness compared to the shot. I think most of us believe it's probably a little bit more effective, but you also do shed virus from your nasal secretions for a couple days after. So there are certain populations where it's contraindicated. So in immune-compromised patients, you don't want to give them the attenuated live vaccine. And it is an attenuated vaccine. It's not the fully virulent influenza virus. I think one good reason to give it is, one, it works very well, but also it saves the kids a shot. And and parents, again, when you're thinking about compliance and convincing people that it's a good thing to do, I've got 3 kids. It's much easier to stick a syringe up their nose and inject than to stick a needle in their arm, when that's a reasonable alternative.
I was wondering if you have any idea of where this whole vaccines cause autism idea actually come from. Where does that stem from?
Well, it's Andrew Wakefield, the study I showed that was published in The Lancet. So it was his study on 12 kids that supposedly linked neurodevelopmental disorders with some unusual inflammatory conditions of the bowel that occurred after receipt of the triple vaccines, MMR. So the theory was that some things were leaking across the gut that were getting into the brain and affecting its development. But really the study was very flawed from the start, very biased, and there have been dozens and dozens of studies by many groups from all over the world who have looked at that and said that is not true. So in terms of truth, the truth meter that you were looking at, MMR is not associated with autism. Now, autism surely has many complex causes, and maybe inflammatory bowel or unusual bowel conditions might be somehow genetically linked or something, but not in this case. But as I showed, it took a decade and is still taking time for England to deal with the consequences of that paper.
I think, could I add one thing to that,
Sure.
too? I think the other thing is, if you think about when the clinical manifestations of autism often present themselves, so typically kids aren't verbal until 12 to 15 months. And so a lot of the behaviors that show up forget the vaccine for a minute, show up after the first year of life. So there is often a temporal association. So they get the shot between 12 and 15 months, and then that's when the signs of autism start to emerge. Babies in the first year don't do a lot but eat and coo and fun things like that. So you're not going to notice whether or not they have any behavioral issues. So there's that temporal association that then is supported, in quotes, by this faulty science, and that kind of, I think, helped facilitate it as well.
I could just say something too, having worked in the field of autism for over 20 years, their parents have tended to be, well, there's a lot of highly educated individuals who are extremely vocal and have a lot of power and have done an amazing job, like Lisa was talking about, in terms of putting forth, and some of it is pretty out there, but some of it is actually quite well documented on videos with their children prior to, and it's very powerful. Some of it, I think is a little more extreme, but some of it is very reasonable sounding, and it's very powerful. And parents are quite desperate to find a reason for why their child is not who they had hoped their child to be. So. Last question?
I just have 2 questions. Didn't that researcher make a public apology for his faults? Was it a different researcher?
He's living in Austin, Texas. He left the UK in around 2004 or so, and is living in Austin, Texas, pursuing this and being a supporter, and has, he's a messiah for lots of people. And I think what Nancy just said is very important when we think about all sorts of diseases. You have a bright cohort of parents who are desperately trying to find an answer for their child, and they look to all sorts of things. And we do that with many other diseases, where you have an unknown cause for disease with a tenuous but possible link to an infectious agent, whether it's Lyme disease, whether it's chronic fatigue syndrome, other things, and they take it and run with it, and it's hard, and you just have to be sympathetic. And they're not, these people, their intent isn't to bash really MMR, it's to try and provide support for parents and kids and say, okay, look, if it's possible, let's think of another way to deliver a vaccine.
Well, thank you all for such a stimulating afternoon.